is what we've seen in our data, that has no hydronephrosis. Hydronephrosis is when you're blocking the ureters back to the kidney, and basically fluid builds up back to the kidney. The kidney isn't draining it as well. When there's evidence of that, usually surgery or cystectomy up front is going to be better. Similarly, again, while we've gone over a complete resection is better than not. If you have extensive carcinoma in situ, our approach is probably, chemoradiation is not really a treatment for carcinoma in situ. So if you have evidence of a lot of that along with your bladder tumor, we usually shy away from bladder-sparing therapy and recommend cystectomy. Your kidney's got to work well so that you can take chemo. So that a lot of the chemo we use is what's cisplatin, is one of the main chemotherapeutic agents, and that requires you to have well-functioning kidneys in order to get that treatment. And transitional cell carcinomas are the main histology from the pathologist of most sort of the garden variety of bladder cancer. But there are other histologies, and there are rare ones. There's squamous cells, there's small cell, there's this, that. And we can't really say that bladder sparing is as good as cystectomy in those patients because we just haven't really done it in that many, so we don't know. So how does bladder sparing compare to upfront cystectomy? These are just basically a lot of caveats I'm afraid it's a pretty simple question, but it's actually kind of hard to answer that. One of the reasons it's hard is that when you do a cystectomy, you get more information about the tumor. And what we know, and studies from my group have shown this as well, that a patient who is thought to be T2, just muscle invasive, up to 30 or 40% of the time will be upstaged at time of cystectomy, meaning although they thought it was T2, it really turns out to be T3. Okay. Now, we don't get that extra information when we're doing chemoradiation because we're not removing the bladder and removing the whole tumor. And so sometimes what I'm basically saying is you're not comparing apples to apples. So there's a lot of caveats to comparing upfront cystectomy to chemoradiation. But if we do our best job, next slide, please, we'll see that if you just look at the 5 and 10-year rates, this is overall survival. So you have to remember a lot of bladder cancer patients are elderly. They're in their 70s, so they're going to die of other causes. So although some of these numbers look lower, this is not just due to bladder cancer. This is just 10-year survival based on all causes. But what you can see if you look at 5 and 10-year numbers in big cystectomy series from Southern California, Sloan Kettering, and others, compared to big chemoradiation series, is that the numbers are pretty similar. So for when you try to make apples to apples as best as possible, we think that chemoradiation offers as good survival of bladder cancer as cystectomy. There has been one attempt to actually do a trial comparing the two. And it's been done in the UK. The UK can pull off trials where they randomize a patient who comes to them with bladder cancer, for example, to surgery or something else. You can't really do that in the US. American patients aren't that willing to be randomized, especially when it's surgery or no surgery, right? It's a tough thing to accept. So these studies are actually very hard to pull off. And if you really wanted to answer the question, well, are they the same or is one better than the other, that's the kind of study you'd have to do, where it's a flip of a coin deciding do you have cystectomy or bladder sparing therapy first. They tried to do it in the UK, next slide, and it didn't work. They couldn't get enough patients to randomize. And so they had to end the study very prematurely. However, in the UK, bladder sparing therapy is the primary approach to invasive bladder cancer, interestingly, unlike most other countries. And what they were finding in this study is that most patients wanted, if they could choose, bladder sparing therapy. They didn't want surgery. And so this is the problem why they couldn't pull the study off. Patients weren't, again, in the UK, willing to be